All right, let's go ahead and get started. Thank you for joining us this evening. I'm Jeff Howell, the Executive Vice President of the Missouri State Medical Association. I'll be the moderator for this evening's webinar. We're excited to present the final webinar in our You're a Doctor Now What webinar series. This series is being brought to you by the National Mental Health Collaborative, which is a nonprofit organization established by the Arizona Medical Association, Missouri State Medical Association, and Wisconsin Medical Society. The collaborative has a mission to promote and advance the healthcare field by providing education, policy development, and resources aimed at improving the delivery of patient care. That includes this educational webinar series. If you're interested in learning more about the collaborative, please reach out to any of the 3 medical associations. Tonight's webinar will be focused on the important topic of health equity and diversity. I'm pleased to introduce Kimberly Ramseur, who will be presenting on the topic of health equity and diversity. Kimberly is an experienced healthcare policy and equity professional with a demonstrated history of providing solutions to access to care problems through advocacy and education. Currently, she serves as a senior policy analyst with the Center for Health Equity at the American Medical Association. Prior to the AMA, Kimberly worked for various healthcare-related organizations, fervently learning how to view healthcare and access to care issues through several lenses. She served as a member of the policy and advocacy team at the Hemophilia Federation of America, where she assessed the impact of state and federal legislation on people living with rare bleeding disorders. Served as the health equity lead and developed the Bleeding Disorders Health Disparities Council. She also assisted with policy and advocacy efforts during her time with the Medical Association of Georgia. Kimberly holds a Juris Doctor from the North Carolina Central University School of Law, a master's degree in public health from Georgia State University School of Public Health, and a bachelor's degree in political science from Howard University. Without further ado, I will hand it over to Kimberly.
All right, so thank you so much, Jeff, for the introduction, and hello to everyone. Thank you for allowing me to come spend the evening with you discussing the importance of health equity and DEI in medicine. So before starting the presentation, I'd like to take the time to do a land and labor acknowledgement this evening. Just acknowledging one that I am presenting from North Carolina. I know many of you are in Missouri, some may be in Arizona and Wisconsin, but however, no matter where we are located, there is a shared history, and I want to acknowledge the ancestral lands that we occupy, the brilliance, energy, and life of the people that have lived and labored on such spaces, celebrating the resilience and strength of the Indigenous and African people that have come before us, carrying them with us as we lead this work. So today I have 3 goals that by the end of the session, each of you all should be able to do 3 things. One is understand the value of having a diverse, equitable, and inclusive physician workforce. Be able to describe the direct and indirect ways in which policy impacts access to medical education and the overall practice of medicine for marginalized communities and minoritized communities. And lastly, be able to identify the concrete tools and opportunities for engagement for advancing health equity. And so I'd like to start off with this quote from Dr. Jocelyn Elders, who served as the first African-American US Surgeon General in the mid-1990s. Her quote presents us with so much to unpack. And it starts off by explaining that health is more than the absence of disease, that it is indeed more. It starts a conversation on how health is associated with economics, education, environment, and community, or as we would like to say, the social drivers of health, also referred to as social determinants of health. That when you encounter a patient, you are not simply addressing the existing health need that is in front of you, but in order to fully care for your patient, you must take into account certain other factors that may be impacting their health. And so Dr. Elders goes on to say that the health and well-being of the people is critically dependent upon the health system that serves them. It must provide the best possible health with the least disparities and respond equally to everyone. And this is where I would like to start our presentation this evening. discussing the impact of DEI within medicine and how it plays a role in health outcomes and physician experiences. And so for some, the very concept of overall DEI may appear innovative. It seems as though within the last few years that it's even become very popular, trendy in various conversations, especially within healthcare. And as we have seen the disparate impact that COVID-19 has had on many Black and Brown communities. However, the conversations about race and medicine are not new, those amplifying the underrepresentation of health outcomes in communities of color. So the underrepresentation of Black physicians in America can be traced back to the Civil War, when Jim Crow laws, state and local laws that legalized segregation were enacted. Such laws impacted many areas of life, from hotels, restaurants, movie theaters, to even schools. This meant that Black students who wanted to attend medical school at a white institution were prevented from attending either that school or had to enroll in Black institutions, or if they couldn't get in there, they had to opt for another career path. And so while this may sound like an easy choice, it wasn't. Black medical schools didn't have the means for large classes. So if they couldn't get in there, that means very few applicants were able to be admitted. So it forced a lot of them to pursue very limited employment options. And so while medical schools were being established at that time throughout the United States, only 7 schools were actually predominantly Black. You had Howard University Medical School, Meharry Medical College, Leonard Medical School, also known as Shaw University, New Orleans University Medical College, Knoxville College Medical Department, Chattanooga National Medical College, and the University of West Tennessee College of Physicians and Surgeons. In 1908, the AMA and the Carnegie Foundation solicited the help from Abraham Flexner to conduct a survey of all 148 medical schools that existed at the time in North America. 2 years later, he published the Flexner Report, which transformed medical education in the US. His report, among many other things, included harshly criticism of Black patients, physicians, and medical institutions, stating that if not properly trained and treated, Black people posed a health threat to middle and upper class whites. This critique led to the closure of 5 of the 7 Black medical schools that existed at the time, leaving only Howard and Meharry. And recent research suggests that had the 5 closed schools actually remained open, they could have produced at least 29% increase in the number of graduating physicians in just the year of 2019 alone. So in the 1950s and 60s, there was a peak in the civil rights movement when Black leaders, along with many white allies, advocated for social justice, equality, and diversity within areas like the military, schools, and businesses. And such efforts were in response to increasing discriminatory policies and subsequent treatment that trace back for years. Dismantling oppressive systems, rules, laws, and policies, and attaining equality seemed like the appropriate remedy to help not only Black families and individuals move forward, but the country as well. And this includes medicine. After World War II, the medical civil rights movement began to narrow its focus upon ending segregation and discrimination within healthcare. The National Medical Association, also known as NMA, an organization of Black physicians established in 1895, protested the pro-segregation provisions of the 1948 Hill-Burton Hospital Survey and Construction Act. In 1962, George Simpkins, a dentist, and Alvin Blunt, a physician, and other Black doctors and their patients sued both Cone Memorial Hospital, as you see on the screen, and Wesley Long, arguing that they had been denied hospital staff privileges or the ability to admit patients due to their race. And they argued that the 2 hospitals which had received funds under the Hill-Burton Act had violated their rights under the Equal Protection Clause of the 14th Amendment, and the Fourth Circuit Court of Appeals actually agreed with them. The court held that the separate but equal clause was indeed racial segregation, and that they did not have the right to do that. But unfortunately, at the time, this was limited to only the states within the Fourth Circuit. So While it did lead to some relief there, it only applied to a few states, meaning North Carolina, Maryland, South Carolina, and West Virginia. So it made it very clear to the physicians at the time that more work needed to be done. And so members of NMA demanded an end to the incessant discrimination of Black physicians by the AMA, which at the time stood by as local chapters prohibited Black physicians from seeking membership. This prompted the development of the Medical Committee for Civil Rights. The committee made national headlines in 1963 when they picketed the AMA's convention in Atlantic City, holding signs that requested the organization to end all segregation and discrimination in medical care. And in 1968, AMA finally agreed to end its practice of racial exclusion. And as time progressed, advocacy efforts have expanded beyond racism to address sexism, ageism, ableism, homophobia, xenophobia, and other forms of oppression overall, and certainly in medicine. And while we have seen some changes over time as new rules and regulations have been implemented and many discriminatory laws and policies have been challenged and subsequently amended or abolished, there is still room for improvement. The physician workforce continues to lack diversity, and attempts to increase representation have yielded very slow growth. And so according to recent statistics from the Association of Medical Colleges, about 1/3 of physicians identify as female. More than half of practicing physicians identify as white, 17% as Asian, 6% as Hispanic, and 5% as Black. And when we consider the socioeconomic diversity, we find that the majority of medical students come from more affluent or higher economic social status backgrounds. And so lack of diversity can impact any area, but in medicine, it can limit the reach of care by taking a one-size-fits-all approach to assessing patients. These experiences in overall treatment, if the goal is to provide genuine patient-centered care and in an effort to improve health outcomes, then the care team should resemble the community in which they serve. It's not just what sounds good, it's the same as echoed by patients. And so finding a provider who shares the same race and/or ethnicity is actually a priority for many. According to a University of Pennsylvania study published in 2020, patients across multiple racial and/or ethnic backgrounds preferred healthcare providers who shared their same and/or ethnicity. So it is critical that we don't limit ourselves to just sharing race and/or ethnicity, as people have additional identities and many of them often intersect. Having a healthcare provider who looks like you or shares something in common with you can mean different things to different people. For some, it may lead to a stronger sense of connection or the belief that the patient and provider have shared life experiences. If patients feel more connected to their physician, they may be more willing to openly communicate about their health and health experiences, as well as trust and subsequently follow the physician's recommendations, which could lead to better health outcomes. So just take a look at some of the stories I've highlighted on the screen, each one detailing the benefits of having a diverse and inclusive team. And sadly, this isn't always the case. So recall some of the statistics that I said from the previous slides. Depending upon where one lives, patients may not always have access to physicians that look like them, speak the same language, practice the same faith, or be accepting of lifestyles that do not align with their own. While much of society has become more accepting of different gender identities and sexual orientations, members of the LGBTQ plus community continue to face stigma and discrimination, which are major stressors. Such experiences can have a number of negative consequences on health every day, from everyday functioning for LGBTQ members of all ages and races, including increased risk for poor physical and mental health outcomes, and dangerous health behaviors. For example, The risk of suicide is extremely high among young, many gay, lesbian, and bisexual adults. And surveys show that half of transgender and non-binary youth in the US have considered suicide within the past year. Such experiences are not limited to patients alone. US physicians and students are not immune and at times are faced with some of the same challenges and more while juggling both your personal and professional lives. So having someone you can go to who has shared experiences and or understanding can be beneficial in many ways. And as we continue to make the case for having a diverse physician workforce, we have to consider the foundation, your education. So what you learn or don't learn and who you learn it with, or even who you learn it from, can impact how you not only practice medicine, but how you interact with others. So according to Dr. Paul Rothman, who is the former dean of the medical faculty and CEO of Johns Hopkins Medicine, students trained at diverse schools are more comfortable treating patients from a wide range of ethnic backgrounds. So even while you're not sharing a patient's race, physicians who have learned with and around others with varying backgrounds can still have meaningful patient and provider relationships capable of yielding some of the same previously mentioned results. Understanding how race, ethnicity, sexual identity, or socio-demographic factors affect a patient's needs can improve outcomes, but this requires physicians who understand the diverse backgrounds of our patients, and this happens when diversity in medical education increases. And so this also includes the materials being used to teach. So last year, an image of a Black fetus within the womb of a Black woman went viral. Some social media users of all backgrounds were in awe, acknowledging that they'd never seen a medical illustration before featuring a Black body. And so the self-taught Nigerian medical school student, Chirdebe EB, took notice and wanted to change that. He figured that he would be the first one to go about changing that. And so he wanted to make it his priority to produce such images. And so resources such as these provide students, researchers, and clinicians a visual tool that can assist with their ability to assess, diagnose, treat, and communicate better with patients and other healthcare professionals. And so as I previously mentioned, recent data shows that medical school matriculation among underrepresented racial and ethnic groups has increased at its highest level so far. The same cannot be said for faculty. A study this year with the goal of evaluating trends and associations in faculty diversity of the US medical schools over a 5 period found that from 2014 to 2018, female faculty increased modestly, while in the underrepresented in medicine category remained flat. Those who identify as female and part of the underrepresented medicine group were also less represented at the professor level. And moreover, faculty in the underrepresented medicine group were less represented in higher ranking institutions as well. So this is yet another area for an improvement. And I think it is also critical for me to note that recruiting diverse populations is not simply enough. The process also requires taking an internal look at some of the systems in place that have led to a lack of diversity and or even maintaining such spaces. So we should also prioritize retaining individuals, creating environments of inclusion and belonging so that once they enter these spaces, they don't feel the need to immediately leave as soon as they get there. And so inclusion refers to how our defining identities are accepted in the circles that we navigate. Belonging evolves from inclusion. So it refers to the extent in which individuals feel they can be their most authentic selves and can fully participate in all aspects of their lives. So inclusion is a state of being valued, respected, and supported. Building environments of inclusion and belonging not only help to facilitate recruitment of diverse voices, but also retention. By creating safe spaces for people to freely express themselves, learn, and grow, you're likely to see retention rates increase. And in educational settings, this means increased opportunities for having mentors that have shared experiences or those that differ and can be opportunities to learn something new. And the same thing can be said upon graduation as well as when entering into practice. And so overall, over the years, there have been consistent efforts to create and sustain inclusive environments in conjunction with building diverse medical education programs and an overall physician workforce. But of course, there have been threats. And so this past Monday, the Supreme Court began hearing oral arguments for two cases, students for fair admissions versus University of North Carolina and students for fair admissions versus President and Fellows of Harvard College. These cases were originally joined as one, but were severed so that our newest Justice Ketanji Brown Jackson, could participate in at least one of the cases. So she recused herself from the Harvard one since she attended both Harvard undergrad and law school and also served on their board of overseers. But here in the case, the challengers, students for fair admissions, argued that Harvard and UNC's admissions process violates the Equal Protection Clause principles and discriminates against Asian Americans under Title VI of the Civil Rights Act. And they're seeking to have the court overturn long-established precedent and suggest colleges consider the development of race-neutral alternatives to achieve diversity. And so for both cases, the court must consider this question: whether colleges and universities can continue to take race into consideration as a factor in their admissions process. And this does include medical programs. US medical schools have for decades positively considered race when deciding which students to admit. It's one of the parts of the equation, along with test scores, grades, and individualized interviews when determining the mix of students that will result in a class of physicians best equipped to serve all the nation's patients, as many of you already may know. And there's a strong chance the court will rule in favor of student admissions and undo years of precedent, given the comments and line of questions that we heard on Monday. And if that is the case, it will certainly reduce the diversity amongst student populations at various colleges and universities, which is evidenced by what we have seen so far in states already that have done so, like California, Oklahoma, Arizona, Florida, and Nebraska. And so in response to those challenges, AMA has jointly filed an amicus brief in support of both Harvard and the University of North Carolina. And AMA's president, Dr. Jack Resnick, has also provided comments expressing his support as well as for the institutions, and reiterated the importance of having a diverse physician workforce. And in addition to this, AMA has reaffirmed its commitment to equity and will continue to take the necessary steps forward by continuing its mission of embedding equity both internally and externally. And so, of course, this work has been in place for now prior to the two aforementioned Supreme Court cases. The Center for Health Equity was created in 2019 in response to the adoption of a House of Delegates report calling for the development of a unit that would lead the AMA's health equity activities. And in just a few years, we've gone from a unit of 1 to a team of over 50. And last year, we published the organizational strategic plan to embed racial justice and advance health equity, which includes 5 main approaches to addressing inequities in healthcare from the AMA, and they are: 1, embedding equity, where we seek to implement equity strategies through AMA practices, programming, policies, and culture; building alliances with marginalized physicians and other stakeholders to elevate the experiences and ideas of historically marginalized and minority healthcare leaders; push upstream, where we seek to strengthen, empower, and equip physicians with the knowledge and tools to dismantle structural and social health inequities; ensure equitable opportunities in health innovation; and lastly, fostering truth, racial healing, reconciliation, and transformation by accounting for how internal and external policies and processes excluded, discriminated, and harmed communities. And so AMA's efforts to advance equity didn't just start with the creation of the Center for Health Equity. Despite its history of excluding physicians from minoritized or marginalized groups, AMA has taken steps throughout the years to reconcile with its past. And here are just a few policies adopted in the 60s and 70s that showcase efforts made to advance equity, from encouraging internships from internship programs to accommodate working women with families, to creating increased opportunities for women physicians, to even building alliances and working with external groups to create expanded opportunities for women to pursue medical careers. And so here are some additional policies that have been adopted throughout the years to advance health equity for other minoritized groups from 1995 to 2020. And so this is just a small sample of what's currently in place. Many other policies have, of course, been adopted, but I unfortunately did not get a chance to include all of them. I ran out of space on the screen, but still wanted to provide just a snapshot of what is in existence from those years. And one of the ones that did not include or was not included on the previous slide after 2020 year was this one, for example, which came out last June. And this policy was adopted at the annual meeting at that time. Earlier, we discussed the Flexner report and the resulting outcomes, the closing of several medical schools and institutions, including the majority of Black medical programs that existed at the time. This policy serves as a path forward towards reconciliation by encouraging diversity in medical schools, enhancing existing pipeline programs, and most importantly, it recognizes the significant harm that the Flexner report caused to Black medical schools, physicians, and the physician workforce, and of course, minoritized and marginalized patient populations. And so with each meeting, we continue to see increased efforts to adopt equity-related policies. And so one aspect of my job includes reviewing all the resolutions that have been submitted for consideration at each meeting of the House of Delegates, and I and the rest of the team will tag them for having any potential equity impact. And there were at the annual meeting this summer, there were over 260 resolutions submitted, and we flagged over 90 having health equity implications. And for the upcoming interim meeting, we have flagged at least out of 210 resolutions, over 100 as having health equity implications. So some of them that you may have seen or even assisted with as well. And so this is truly something to be said about how much equity is being prioritized. And I look forward to just tracking and following them throughout the House of Delegates process and possibly working on them as well. And so just a quick note for anyone who plans to attend the interim meeting in person in Hawaii. If you have time, I do encourage you to attend the Health Equity Open Forum that will be taking place on Saturday, November 12th. From 2:30 to 5 p.m. So if you're there, you should definitely attend. And so in the next few slides, I just want to take some time to just highlight some additional opportunities for engagement, starting with the Medical Justice and Advocacy Fellowship. This fellowship is a collaborative educational initiative to empower physician-led advocacy that advances equity and removes barriers to optimal health for marginalized people and community. It mobilizes physicians to be part of the next generation of advocacy leaders, driving meaningful policy and structural changes that produce equity and justice in the communities they serve. The program is open to all physicians and residents who have a demonstrated interest in health equity and health advocacy, and runs for about a year, providing both virtual and in-person learning experiences. And currently we are in our second round of the fellowship. So if interested, please feel free to reach out to me or somebody else within the Center for Health Equity if you have a contact. Definitely could put you in touch with the right person if you have any questions or interest in applying to the program. I've also provided links to the website for more information in the slides. And so another fellowship opportunity that I wanted to highlight is through the AMA Foundation, which is seeking to dramatically shape the future of LGBTQ plus health through the National LGBTQ plus Fellowship Program. by supporting institutions and fellows to create a more robust pipeline of LGBTQ plus health specialists who will be able to serve the healthcare needs of the LGBTQ plus community, as well as serving as a convening force to move the needle in LGBTQ plus health equity by bringing together leaders in healthcare, the LGBTQ plus community, medical education, community organizations, and other stakeholders. And so for additional information about this program, please check out the website. I provided the links to the website in the slides as well here. And so launching later this year, the Rise to Health, a coalition for equity in healthcare, will bring together individual leaders and organizations representing key audiences and others who are currently leading health equity and justice work to collectively identify solutions, create frameworks, and share such resources with the broader healthcare ecosystem to advance equity. And I mentioned earlier that there will be a health equity forum at the upcoming interim meeting. An overview of the Rise to Health Coalition will be provided by some of the key leaders working on the project there. And I also forgot to mention that many of the medical justice and advocacy fellows from the first round will be there as well to present at the forum discussing their equity work so far. So it'll be a great opportunity to learn and connect. And again, it will be on Saturday, the 12th from 2:30 to 5 p.m. And lastly, earlier this year, members of the Federation team at AMA, as well as some of the staff members from the Center for Health Equity, we started to conduct monthly listening sessions with various state and specialty societies. And so the purpose of these sessions are to create collaborative spaces for us as staff to really get a chance to learn more about the individual work that you all are doing, as well as amplifying the work and identifying ways in which we can support you in your health equity journeys, as well as give other members of the Federation a chance to connect, learn, and grow. And so far, we've had about 7 meetings from a host of different organizations on a variety of topics. And next month, we look forward to hearing from our friends in Alabama about the equity work that they have done and looking to do in the next few months and year. And it's been very enlightening to just hear all of the work, to see the level of engagement at each session. And I'm not sure if any of you all have been able to join or attend any of the meetings, but if you're interested, of course, again, feel free to reach out. If you are looking to attend as a listener, we'd be delighted to have you. And if you also want to join as a presenter as well, again, feel free to reach out to me or a representative. All right, so I just wanted to close out with the same quote that we started with, just as a reminder of how we started, and hoping that you all gain something from this presentation, and just really looking forward to hearing from you and seeing all the work that we can accomplish together. And if there's any questions, I'm happy to take questions or any comments that you may have. But lastly, also wanted to say thank you all again for having me. And a huge shout out to Jeff and team for putting this all together and inviting me to come speak with you all.
Okay, thanks, Kimberly. I don't see anyone with any questions. Kimberly, I have a question. How can, like Missouri, for example, we haven't really started doing any work in this area. What's a good way for a state medical association or a group of a residency program or a group of medical school students? What's a good way for them to kind of dip their toe in the pool and get started with doing some DEI work?
Yeah, I mean, I do want to plug again the health equity sessions that we do held monthly, because I think that if you've never done any of the work or just curious about what others in medicine, be it from other practicing physicians or medical students are doing, it's a good place to at least just hear what others are doing first, just to get an idea of where everyone is, and just understanding we're all in different places. And so it's good to get an understanding of the work that's being done, but also acknowledging like you don't have to start out as an expert. So I think one, that would be a great place to start. I think that the other opportunities are around, if you're ever given an opportunity to go to annual meeting, interim meeting, where we're hosting sessions there, attending in person where we can meet and talk in person together. But throughout the year, we have a lot of resources and programs that we put on from our Prioritizing Equity series that are online that you can watch. And also we have on our page a lot of health equity one-on-one resources. So if you are not attending the sessions in person or online and really just trying to get a one-on-one session, it's a really great resources there to just get your feet wet and get a really great overview of some of the work that we're doing here at AMA, but then some of our other colleagues in other spaces are working on. So just trying to, throw out different resources, just depending upon how you want to start to engage in the process. And of course, I'm always here to talk and connect you to other people if I can't assist as well.
Great. Well, I want to thank you for the time tonight, and it's definitely appreciated. And this being our last, I'm a Doctor Now What webinar. I want to remind all the attendees that they can find the presentations online, and just to send me an email if you need to be directed to those. So, Kimberly, thanks for your time tonight, and everyone have a restful Sunday evening. Thank you very much. This will end the webinar.
Thank you.